This is QD Clinic. Hi, I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live 2024, coming in 2 weeks. Be there, be square. It's for you if you're interested and you want to be informed or inspired. That's what our content is all about. Today's case is a 64-year-old seropositive RA patient who is on certolizumab and methotrexate and analgesic medicines, a little bit of Advil, folic acid, pravastatin. That's about it. She's in because she has, in addition to RA, severe osteoarthritis in both knees and has a right knee effusion. It's cool. And the question is, if I'm going to inject that knee, and I'm sort of actually not a big fan of joint injection, but I think this is a good situation. She's otherwise RA controlled, right? Her, what's her disease activity scores here? She really has no swollen joints other than the 1+ effusion, cool effusion in the right knee. And the question is, if you're going to inject her, whether you use triamcinolone or depomedrol as I do you do arthrocentesis before you inject the steroid? I must say that I have done this many times, both ways. And, the question is, what does the literature say? Because my, experience is really N of 1, because I'm not going to remember the last 45 or 60 times I did this. So I looked this up, and it turns out that arthrocentesis prior to corticosteroid intra-articular injection is more effective, significantly so, like P.001 and less than that. So I'm looking at a few studies, one to 150 patients, and they were randomized in this study to either withdrawal of fluid or no withdrawal of fluid after getting 20 milligrams of triamcinolone, and these are RA patients, not OA, although I'm sure there was some OA. The bottom line is that there was a significant difference with as much as a 40% difference in relapse rates, and they went out 200 days. So that's, 7 months or so. And the relapse rate on the no arthrocentesis group was, at least 35 points better, 35% better at 7 months. So again, it's not what I wanted to hear, because I kind of want to, go and the point. And I guess what are you going to do? Are you going to do what I do, which is if it's a good size or a large size effusion, yeah, I'll drain it. If it's a trace effusion, is it worth it? Where you may not get fluid out, I won't. And what I'll do is I'll try to put in as much steroid as I can, and I'll try to dilute it as much as I can with lidocaine to get better spread of the steroid to the synovium and the synovial membrane inside. So that's how you should approach intra-articular aspiration and injection in an RA patient. Tune in for more QD Clinics.